Good afternoon. Greetings, everyone. Welcome to the School of Communications, Webster University Health Communication Summit. Thank you for joining us today. My name is Eric Rothenbuehler. I'm the Dean of the School of Communications at Webster University and host of this event, but we, of course, have many people helping us to pull it off. Health communication in pandemic and beyond, opportunities, needs, and challenges. We've gathered a very interesting panel, 2 panels worth of experts, both regional and national experts and leaders in every facet of health communication. First, to help us get started, I'm pleased we have the opportunity to introduce President of Webster University, Dr. Julian Z. Schuster.
Thank you, Eric. Thank you, and I am delighted to have an opportunity to say a few words as opening remarks or whatever you want to call it, about this, I would say, timely and extremely important conference and gathering of individuals, and most importantly, exchange of opinions and ideas about the health and communication. I'm delighted that Eric had put this panel and this conference together with his support of his able team, and I wish you the best of luck and the success. Thank you so much.
Thank you, Julian. Your comments are very apt for us, leads directly into our theme. Let me say to the audience first, before we begin, we're going to send you 3 brief polling questions. We just want to know a little more about you. So you can go ahead and answer those questions while I'm speaking. Oh, look, I see I just got a poll. Let me see. You can go ahead and answer those while I'm speaking. The pandemic, as President Schuster has just described, has illuminated the essential roles of communication in health processes and health practices, whether it's in the clinic, in the health organization, in communication media, public discourse, in advocacy or policy processes. In less pressured times, we take communication for granted. We don't think of health communication so often as a problem, or at least those of us in the general public don't. But the pandemic has illuminated those issues and put pressure on things that we can do without much thought in more normal times. The pandemic has also brought changes to healthcare. How many of us have had a doctor's appointment by telemedicine in the last 6-8 months? That's probably not going away, and that's a communication technology and a communication practice. There are other changes in healthcare and health communication that are probably going to endure the pandemic. So to discuss these topics and to inform our own work here in the School of Communications, we've gathered a group of experts, leaders in the field and experts in every aspect of health communication. Our work here in the field, for us, these visiting experts are advisors. They're expert advisors as well as interesting speakers for a conference, as we work to design curriculum that serves the public good while also providing quality professional education and career opportunities for our students. So I'm going to be very brief so that we save the time to hear from our visiting experts. On our first panel, addressing communication in healthcare settings, we have Diana Mason. Diana, you want to wave? We have Diana Mason, Senior Policy Service Professor in the Center for Health Policy and Media Engagement at George Washington University School of Nursing. Jana Telfer. Jana, wave hello. Strategic Projects Officer, National Center for Environmental Health and the Agency of Toxic Substances and Disease Registry in the Center for Disease Control. And we're grateful that she's available today. Bob Davidson, System Vice President, Marketing Operations, SSM Health here in St. Louis. And Bob is a School of Communications alum. I'm always proud to mention. And our colleague from Webster University's Department of Professional Counseling, Diane O'Brien, has joined us, and she'll be offering a few comments in the role of respondent. And at the end of the panel and before we transition into open discussion. On our second panel this afternoon, addressing health communication in public settings, we have Stephanie Zoller, the Public Information Officer of the St. Louis Metropolitan Pandemic Task Force and Communications Manager for SSM Health. And Stephanie is an alum of the Business School here at Webster. Kara Anthony is a Midwest correspondent for Kaiser Health News, based here in St. Louis. Courtney Stewart, Vice President of Strategic Communication at Missouri Foundation for Health and a School of Communications alum. And Ellen Wartella is the Sheikh Hamad bin Khalifa Al Thani Professor of Communication and Psychology, Northwestern University, in the Center on Media and Human Development. And a colleague from the School of Business in Health Administration, Dan Mueller, will be joining us later to offer a few comments in the role of respondent, again, before we transition into open discussion. Throughout the afternoon, Gary Ford, who you can also see here, Webster University Professor of Communications and Journalism, he will be monitoring the Q&A function. So when you have questions for the panelists, type them into the Q&A function, which you'll see down at the bottom of your screen. And Gary will be monitoring that and select questions that he will voice for the panels. So now, without further ado, let's begin our first panel. Communication in healthcare settings, clinical, organizational, patients, and providers. And we will start today with Diana Mason of George Washington University. Diana?
Thank you very much, Eric. I'm actually going to be very focused in my remarks and bridge the healthcare organizations and the public sphere and look at who is considered authoritative sources on health, on healthcare, on COVID, and what difference does it make when we communicate to the public. And to start, I want to give you a little bit of background about regarding a study. Let's see here, I'm going to do that. A couple studies that I've been involved with. And let's go to slideshow. 1 second. Okay. My computer's being very slow this morning. Okay, so while the slide is coming up, there was a study that was done in 1997 called the Woodhull Study on Nurses in Media. And there you go. No. And what it did was to look at the extent to which nurses were represented in health media. It was commissioned by Nancy Woodhull, a founding editor of USA Today, after experience she had with a nurse who really helped her with a health condition. She was an advocate for women in news media. They looked, this was done at the University of Rochester. It looked at 7 leading national and regional newspapers, 3 news weeklies like Time Magazine, and 3 trade publications such as Modern Healthcare. And what this study found was that we were rarely quoted in healthcare news. In 1997, we were used as sources in only 4% of newspaper stories on health, 1% in weeklies, and 1% in industry publications. In Modern Healthcare, we were cited as sources 0.6% of the time. So I was interested, as was this group, in looking 20 years later, has anything changed? Study was published in the Journal of Nursing Scholarship, and it's available. So I'm not going to go through methods. We replicated that study, and what did we find? We found that nurses were cited in newspaper stories 2% of the time. Weeklies came up a little bit. Industry publications such as Modern Healthcare, still 1%. Now, the difference between 1997 and 2017 isn't statistically significant. So we're not saying things have gotten worse. We're saying things have gotten no better. They are unchanged. Mostly were quoted and used as sources about stories about nursing. We are absent from stories on policy, and in 2017, repeal and replace Obamacare was hot on the policy agenda. We were not in those stories. And so we wanted to understand why, and I think this is the richer of the two studies. It was published in the American Journal of Nursing in 2018. We interviewed 10 health journalists and found it was a qualitative study. The main takeaway was that women, nurses, and positions of authority, there are biases about these things that really impede journalists' use of diverse sources in health reporting. And I want to highlight just a couple other sub-themes. There are editorial biases, almost to a person. The people we interview said, if I'm doing a story on healthcare, not on nursing per se, and I interview a nurse, I have to justify that to my editor. I don't have to justify ever using a physician. And their editorial policies, most media outlets use the Associated Press style book, and that style book says you do not use RN after a name, you can use degrees. That's a whole other Pandora's box, though. They did update their style book in 2018. So there are a lot of biases in the newsroom. Second, journalists don't fully understand what we do. Now, they're not unique. If you go home and ask somebody you live with, what do you think a nurse does? You might think it's okay, but you won't if you're a nurse. I've had to do a lot of education at home to describe to my husband what it is that nurses do, as well as to people in my family. And so that really is a barrier for nurses, journalists reaching out to nurses, and for people to understand that nurses have really unique perspectives and experiences. But this was particularly stunning to me. They told us consistently that when they went to the communications or PR staff of a healthcare organization like a hospital or a university with a school of nursing and asked for a source on a story, maybe it was diabetes and some new research that had come out, nurses were they were almost never given nurses as a source. And even if they asked for a nurse, they sometimes did not get a nurse. And finally, nurses and nursing organizations were not very strategic about accessing, engaging journalists. So there's part of the responsibility is on us. So I want to stop that and just, what is the relevance of that in a time of COVID? Well, first of all, while I'm talking about nurses, I want to point out that social workers are rarely interviewed. Physical therapists are rarely interviewed, unless it's a story about social work or physical therapy. We talk about a healthcare team. We rarely see the voices of the healthcare team in public media. Nurses in particular, I will say there are 4 million of us in the country, the largest group of health professionals. We are the most trusted by the public for 19 consecutive years. The public has rated us the most trusted health professional. So why would you not want to use a trusted voice when you're speaking to the public? In COVID, nurses have been used as sources. And when did we use them? Well, in surges, and you're still seeing it now, we're using them with showing the angst, the stress, the difficulty, and the wear and tear of caring for people who are very sick with COVID. They're saying, please wear your mask. Wear the mask because this work is too hard. We're seeing too many people die. And so that's important. Early on, nurses were being asked to speak about public health, case contact tracing and case finding, being asked to speak about what was going on with how to protect the public. What could the public do? You're seeing less of that now. And indeed, our experience with Ebola said that after Ebola, the journalists generally didn't care to talk with nurses as sources. And I expect that will continue to wane with COVID-19. But I want to point out that nurses also spoke out about inadequate PPE. And when they spoke out, they probably did not have PR and the organization's approval. What organization wanted to say on record, yes, we don't have adequate PPE, personal protective equipment for our staff? Some nurses got fired when they did so. There is a case of a physician on the West Coast who was fired when he spoke out. But I have to point out that there are double standards for physicians and nurses in terms of public relations and speaking to media. In many cases, the nurse was really choosing between, do I speak out about it to try to put pressure to get better PPE, or do I jeopardize my own life and the health and well-being of my family when I go home if I know I've not been well protected? So that's a real concern, is the muzzling of healthcare providers by healthcare organizations during something like a pandemic, when the frontline staff know that all is not well. I also would point out that we have to ask, what are we not hearing about? So if you're not talking to nurses, you're not hearing that these no visitor policies are resulting in unnecessary deaths because they don't have information about patients who are coming in and can't self-report. What is the impact of these family visitation, the visitation policies and the restrictions? That's an example of what's gone on. Another example is this stress going from one patient you've tried to resuscitate who's just died, and now you have to leave and go to another room. There are some things like the pause that nurses and other healthcare providers are doing to try to regroup, so that when they go to that next patient, who could be your mother, that they are feeling that they're able to give that person the care that they need. So I would challenge us that there are a lot of things going on that we're not hearing about because nobody's asking the right people. And that we need to have that contact with frontline staff, whether it's the people who are cleaning the floors and are very much at risk of COVID and are seeing things that they're not talking about. And that's my timer. What are the sources that we are using for learning about what we need to communicate to the public about, what we need to communicate to other healthcare providers about? And so I'll stop there. Thank you.
Thank you, Diana. That's really powerful stuff, connecting the frontline care and the challenges and difficulties in that moment with public knowledge. If we don't have access through other chains of communication to that experience and the information, the knowledge and information that arises in that experience, we're all deprived from that. Okay, so next, Jana Telfer from the Center for Disease Control. You need to unmute, Jana.
I like to say that mute is my default position. It's a better position than unmute often. So good afternoon. I'm delighted to be here to present an individual perspective from someone who spent the past 2 decades at the Centers for Disease Control and Prevention, responding to emergencies from A, that's anthrax, through Z, that's Zika, and now beyond. But first, a disclaimer. The findings and conclusions in this presentation have not been formally disseminated by the Centers for Disease Control and Prevention, nor any agency, nor any co-author, and should not be construed to represent any agency, determination, or policy, which basically says, if I creep out onto a limb that cannot bear my weight, I am entirely on my own. So in that regard, I'd like to share with you 3 concepts that I've observed over the past many years, particularly in the period from my time in Liberia in the Ebola epidemic through the present. And I believe they have application beyond the present moment as well. So these are the implication of mega crises for communication practice, what it means to conduct audience-centered communication, and finally, the implications of culture for our practice. So starting with the most important one, in my opinion, during the 20th century, our country experienced 3 public health crises that were landmarks: the polio epidemic, health effects of cigarette smoking, and the HIV/AIDS epidemic. By contrast, since September of 2001, when hijacked airplanes flew into the World Trade Center towers, The Centers for Disease Control and Prevention has activated its Emergency Response Center at least once a year and frequently more often. And most of these are for mega crises. Crisis intelligence expert Patrick Lagadec says that a mega crisis is not just a bigger crisis. And I'm going to read this so that you'll get it exactly. Mega crises are characterized by their instantaneity, their overwhelming scale, the complexity to the point of appearing indecipherable, their effect on multiple systems, both simultaneously and over time, and the disruption of the established order in ways that produce substantial systemic change. I'm going to submit to you that the emergency response paradigm that we have used in our country since the 1970s, and both my experience and my research indicate this, is not adequate to the mega crisis epoch. At CDC and communication, in fact, we have shrunk that phased system model to before, during, and after. Now consider, if you're using a 3-step model, we are now more than 200 days into a response of activation. And in this period, we've experienced events starting, surging, subsiding, surging again, all over the country at different times, in different places, in different circumstances. This phenomena is mirrored in state health departments, county and city health departments, and I would suggest to you also in hospitals, schools, and other institutions. I believe a new model is needed for what is now the normal. Not the new normal, it is the normal. Pandemic response has been complicated by the financial upheaval that caused disruption to families, individuals, and entire communities. And then came the hurricanes and the wildfires, and now the cold and flu season. So that disruption bridges me to my second concept, which is audience-centered communication, which I believe is different from a target audience. As Dr. Schuster suggested, in our agency, despite years of effort to advance clear communication, we often just write for ourselves. Consider in the COVID-19 epidemic or pandemic, I recently had a conversation with a couple of colleagues about isolation and quarantine, which our epidemiologists insist on using. In actuality, the public is confused about what's isolation, what's quarantine, and what does it mean? What is that 14-day thing? Really, what we could say is stay home. And if you are ill, stay in your own space so that you can protect your family. But we want to use isolation and quarantine. In the Zika outbreak, our poster from CDC, our premier poster, had a 2-story brick home, very similar to those that we see throughout Atlanta. But my favorite thing that we did was we started almost every communication with Zika is caused by the Aedes aegypti mosquito. Now, my observational epidemiology indicates that not once have I seen someone observe the mosquito that landed on their arm and diagnose which genus and species that mosquito represented before they struck it. So when Hurricane Katrina hit in 2005, we were surprised at CDC to find that the largest population of Vietnamese fishermen outside of Vietnam lives on the Gulf Coast of the United States. 15 years later, we should no longer be surprised about who lives in our communities. When a mega crisis strikes, we have at most 36 hours to determine a clear course of action. And that's while we're doing the regular risk communication that we should be doing anyhow. That means we should, as communicators, we should already know who lives in our communities and where those different populations are located and how they like to get their health information. We need instead to use part of that 36-hour window, not only to marshal our information, our facts, and what it is that we want to communicate, but also to think about those things from this perspective of the audiences that we want to serve, our communities. What is it that they want to know? What crucial things are essential for them to know? In Oklahoma, for example, we sent a team during this pandemic to help people increase their usage of masks. It was a team of scientists with whom I've worked who are experts, not only in health communication, but in science. And what they found was, as they were trying to find ways to persuade people of using masks, what was most important to people was the economic collapse in the community. They needed to know where their next meal was going to come from. They needed to know how they were going to pay their rent or their mortgage, how they were going to shelter their children, how they were going to manage the educational challenge that they were facing. Not until we were able to address those things and help put people in touch with resources that could help them with those, could we talk about masks. Which bridges to culture. Now, I have worked all over the world. It's one of the privileges of working at CDC is that we are not only a national organization, but we have a global activity as well. Our nation is increasingly diverse. For example, more Somalis live in Minnesota than in any other state in our union. And the second largest population of Hmong also lives in Minnesota. Now, these are both people from tropical and arid climates who have moved to one of the coldest places in the United States. During the response, we sent a team to Elkhart, Indiana. Their job was to work with the Hispanic, Latino, and Amish communities, specifically to help the county health department communicate more effectively with these communities about what they needed to do to protect themselves. Culture mediates how we identify ourselves, how we perceive the world, and culture functions to amplify the successes of the group. When we at CDC make public health recommendations, such as wearing a mask in the United States, or in the case of Ebola, changing burial practices, it is more than just asking people not to use so much salt or not to drink so many sweet beverages. And coming from Atlanta now, I can tell you that it's very difficult to get people to stop using salt and stop taking sweet beverages, particularly Coca-Cola. We're asking them to change their values, to change the way they see the world. And if we're going to make this kind of ask, we must consider how to make our recommendation serve and amplify the culture of the people that we're serving. So those are some things I've been thinking about, and I hope they'll stimulate some thought with you. Thank you.
That was excellent, Jana. Thank you. Thank you very much. A really nice model of three key points, three important shifts in perspective on communication that would result in more effectiveness and better service to the public and the people who need the information and the communication. So our next speaker, Bob Davidson from SSM Health, is in a position to bridge all of these topics with responsibility for both internal and external communication of a large, modern hospital system. So Bob?
Thank you, Dr. Rothenbuehler. And thanks to everyone who's joined us today to hear about these important topics. You know, I think as Dr. Rothenbuehler spoke to, there are a great many directions we could go with comments from SSM Health. And I guess for my part, I'd like to touch on a little bit of the business perspective and the business communications perspective. So for us, this 7-month period that feels like it started 3 years ago, it began with a few warning signs that something big was coming, and people who we know and respect a lot had a lot of concern about it clinically. And as we all have come to find out, they were correct to be concerned. And we have felt our way, to be candid. I feel like we as communicators have tried to do the best we can. We've tried to adapt and remain flexible to things as they arise. And I feel, generally speaking, we've done a pretty good job of it. I'll say that in the early days of this pandemic, the first few months, we were hit extraordinarily hard in terms of operating revenues for the health system. And that's important because this allows us to continue to foster our mission and to care for the poor and underserved and all of these types of things. So we saw about a 50% decrease in our revenues in the early months. And with the reopening of elective surgeries and other procedures later in May and into June, we began to see that turn around some. What's a little bit chilling for us now is that even though we've begun to travel in a much more optimistic direction in terms of our performance that would sustain our ministries, we have in all of our communities, SSM was in 4 states, and in all of our communities, we are beginning to see virus spread through those communities growing to critical levels. And we have we are on the precipice of a very bad situation, we feel, in many of our communities that could lead us to pausing those elective procedures. And that could be a problem not only for us as an organization, but for our patients as well, as those elective procedures are very important for their continuing good health. So that's a business perspective. We also, we have a lot of the internal communications work that we do with our group. Stephanie Zoller, who you see on your screen, is an absolute expert at that kind of work, and a privilege to work with her. We've been really addressing a number of things internally and externally, from the scarcity of PPE that our staff needs to do their jobs and to be safe themselves, to just keeping our caregivers informed and engaged, and just really how to help them understand how to be safe while they're doing some extremely dangerous work. There's been a lot of talk of these caregivers being heroes in our community, and I absolutely subscribe to that, but they are human as well, and they get tired and they get discouraged and they get scared. And my gosh, they certainly deserve all of those feelings. But they have really, they're unbelievable in their ability to push through that and to provide care for those in our community who need it. We also have spent a good amount of our time helping and trying to help to educate the public and to educate journalists about what COVID is and how people can best protect themselves. I'll say that, you're going to hear more from Stephanie in a few minutes about the St. Louis Metropolitan Pandemic Task Force, which has been a huge undertaking and is doing some really important work. But the primary thing that we're trying to get people to know and to understand is to wear a mask, to be socially distanced, to wash their hands. And it's become such a message that we've all heard so prevalently that I think it begins to just fall on deaf ears, which is unfortunate, because it's really the best thing we have right now to try to protect ourselves and our communities and all of our families and loved ones. So please do wear that mask. And finally, I'll say in terms of communicating that we have safe care environments for people who need care, it is important not to neglect care for other conditions beyond COVID. If you have a heart condition or a need with oncology, other things, OB is very important, of course. And so we need to be able to help people understand that we are taking a good many steps to make our hospitals and our other healthcare environments as safe as possible for them. And so that's been a big part of our communications challenge and our assignment as well. I think finally, if I have one more minute, I'd like to say that I really appreciate differing perspectives. And I really, really appreciate, some of the comments that my co-panelist Diana made about perspectives on nursing. And we've seen that research too about the importance of the nurses and the reliability and the public opinion of the nurses' perspective. People truly do put a lot of of stock in what nurses have to say, perhaps even more than physicians. And I'll say that Stephanie and I, in the work that we do together, we do put nurses out there, and we do put nurses out there talking about COVID, but we also put them out there talking about some other very important issues like workplace violence and other things. You and I may quibble a little bit on things like, does it make sense to have visitor restrictions? I say yes. And just because we don't have somebody in the hospital doesn't mean we're not still in communication with that person's family member to get all the information that we need. But again, we can agree to disagree, and we can always talk offline too. So appreciate so much that perspective, Diana, and looking forward to hearing from the other panelists on this screen right now as we go along. Thank you.
All right, thank you, Bob. And that's a nice overview and an important perspective when we're thinking about communication. It's easy to forget that there have to be financial resources. There has to be, whether it's a for-profit or a not-for-profit business model, there's got to be revenue, and there has to be a way to fund our activities. All right, so we're lucky this afternoon to have a respondent from Webster's own Department of Professional Counseling. Diane O'Brien is joining us from, I believe, from Myrtle Beach. Is that correct? You need to unmute, Diane. And she'll offer a few thoughts on the three panelists, and then a few of her own thoughts, and then we can transition into discussion amongst the panelists and questions from the audience.
Right. So I am stationed at the Myrtle Beach Extended Campus. I'm actually joining you from my home. I've been working from home since the pandemic began in March. And it so happened that in March, I was returning to work after a prolonged absence for cancer treatment. So the last thing I needed was to be in contact with other people, and I've been working from home since then. First of all, thank you, Eric, for allowing me to be part of this illustrious group. I'm learning things that I guess I hadn't thought of. I'm more of a boots on the ground person during this pandemic. I am teaching. I have a private practice that grows daily. And I do all of my counseling work online, just in this format, a virtual format. So I feel as though I've developed a certain amount of expertise in how we communicate and how we communicate with people when using this format. But before I get to some of those things, I wanted to say to Diana that I appreciated everything you had to say about nurses and the recognition that nurses deserve in the media and in the public. I think that the media, the written media, tends to look for very illustrious titles to use as sources, rather than looking and speaking with the people who actually are working with those affected by the pandemic and who actually understand what this pandemic has done, not just to our country, but to the world. I have the pleasure of counseling with folks in several countries. I have several clients who are in the United Kingdom. I have several in Canada. I see one young lady from the Philippines. And why did they contact me for counseling? The pandemic. The pandemic has exacerbated the cases of extreme anxiety, extreme fear, and depression throughout the world. people are isolated. They're in a bubble, which is what one of my clients told me today. She said, I'm in a bubble. She lives in London, as a matter of fact. So when I had talked with Eric via email about this conference, I had told him that I was interested in spending a few minutes talking about what it takes to connect to people in this medium. In this virtual medium, it's not the same as having a real person sitting across the desk or in the room with you. It's very different. And listening to what others say can be more difficult because you have all these distractions around you. And, oh, they can't see me if I'm on my iPhone, or they can't see me if I'm petting the dogs, or get out of here, little child, I'm trying to conduct business. Listening becomes our most important tool in this arena. And so to let the other person know that you hear what they're saying, and you know, I know you all practice these skills, these basic content skills, reflecting back what the person is saying, summarizing what you've just heard, cueing into how the person must be feeling and saying that. You know, you must be feeling lonely, you must be feeling sad. You must be feeling very proud that you're able to do this virtually. Those things are so critical, particularly when we're talking to folks who have been affected either personally or professionally or both by our current pandemic. And in a world where our health has become politicized, the way it has in our country, in the United States, it's even more difficult because we listen to the pundits talking to us all the time, and yet they're not really in touch with what we're saying back to them, which again made me appreciate everything Diana had to say about nursing. So that's really what the essence of what I wanted to share, is that learning how to connect with people in our virtual world, which is now the norm, and I have a feeling will continue to be the norm even when the pandemic ends. I think this is going to be very normal, but learning how to connect with people that you can't reach out and touch, that you can't physically look them in the eye, although we try to do it virtually, but it's not so easy sometimes. Being able to do that and to connect with others is critical for us.
Thank you, Diane. Very, very provocative. And as a caregiver yourself, you got multiple ways to connect with our topics today. So 4 perspectives, 4 valuable perspectives, from the caregiver to the practice of communication at large, the healthcare organization, the whole organization perspective on managing things, and the flow of information or lack of flow of information in and out of the healthcare setting via the nurse's role in particular, but there would be analogous in other roles as well. So first, I want to offer all of the panelists a chance from anyone, either of the 4 who've already spoken or others would like to speak to each other. So go ahead, Diana.
Yes. So I wanted to make a couple comments to have a bit more conversation here. First, with Diane and your comment, I think the issue is not so much recognition of nurses as it is recognizing that nurses have something to offer in terms of communications with the public. The other is that all nurses are everywhere. And so in the qualitative study that I did, we reached out to health journalists, and a leading health journalist on the business of healthcare emailed me and said, I really, I can't participate in your study because I cover the business of healthcare, so I don't interview nurses. And I had to go back to him and say, do you realize the chief nurse officer is usually the senior vice president for patient care services and manages up to 70% of the hospital's budget? If you wanted to know what impact a decline in revenue or the budget cuts are having on the care that patients are receiving, a chief nurse can tell you that. And so it's recognizing that nurses are everywhere. We have expertise that really could be helpful to the public as well as to journalists. And then I just wanted to point out to Bob, we're not in disagreement. My concern is that we're not looking at the nuances of some of these policies that have been blanket policies. So I have a colleague whose mother was put on hospice care at a major hospital in New York City about a month ago. New York City and New York State have been doing really well. This hospital had not had an admission for COVID in the past week. Her mother was in a private room in hospice care, and she was told only 2 people at a time, and you have to leave at 9 o'clock at night. And her mother, she was also told that her mother only had a few hours left to live. And when 9 o'clock came around, she was told she could not stay. Now, will somebody please explain to me why there's a policy that you cannot stay at 9 p.m.? What is different at 9 p.m. than it was at 8 p.m.? So we have blanket policies. And if we really want to understand the nuances, we should be interviewing the hospital chaplain, the social workers, the nurses, the nurse manager on the unit, and having a conversation about how do we refine these policies in a way that's going to be more respectful of the importance of family contact and the role of family caregivers. So we're not necessarily in opposition at all. I think it's more how do we look at the nuances of some of these issues, which I think Jana also was trying to touch on.
Yeah, I appreciate that perspective, Diana, and I'll agree that I don't think we're too far off from one another. I will say, first of all, I'm really sorry to hear about the situation with your friend's mother, and I know how painful that must have been. I'm happy to say that at SSM Health, we have exceptions for compassionate circumstances. If there's an end-of-life circumstance, people can be with their loved ones in many cases. We hold among our values dignity and respect, and believe that people need that connection. We also sometimes have to make unpopular decisions based on safety of our staff, safety of that patient, safety of the visitor themselves. And this is not a normal time right now. So while I can't fully explain what's going on at the hospital in New York that you described, I can say that we're not perfect at SSM. We had to make some people pretty upset with us because we won't allow them to visit. But we're not doing that arbitrarily, and we're not doing that for reasons of our own amusement. We're just trying to keep the public safe.
I know I haven't been tapped to speak on the other side of the panel yet, but I do have a thought about this, Diana, and I do have to say that a lot of what you're referring to does point to the lack of capacity on the journalistic side. So you can't ignore the fact that while those stories of real people are so important, you have to think about the changing landscape of communications and journalism, and who's telling those stories, and the lack of funding, the lack of support, and where we are with today's news cycle. I'm not going to take too much away from it because a lot of that's going to be covered on our side of the panel. And I know Kara has a lot to say about that, speaking to real folks and how to tap in, getting real stories and getting that information out there. But it's not the same in 2020. And when you don't have those investments, when you're not taking storytelling seriously, and when you no longer have beats You know, journalists have to get in where they fit in. You have to make special investments and turn to other strategies to build that capacity so that those stories and that viewpoint is told. So.
And Courtney, I really appreciate that. I actually deleted a slide on one of the sub-themes from the qualitative study was that journalists don't know how to find nurses and they don't have time to track them down. And so the profession has more of a responsibility to try to reach out to journalists to let them know about the experts that we have in different areas. So I very much appreciate that comment. And the same thing with just the loss of local journalism. It's of great concern.
Yeah. Jana, do you have additional thoughts or a question for one of the other panelists?
I was obviously touched by the concept that nurses aren't used as sources. Before joining CDC, I spent many years at American Red Cross Blood Services. And one of the things that we did, because the nurses were the ones who were out there on the front lines, was to train all of our nursing staff to be able to respond to questions. And we would point the journalists to the head nurse and make sure that they had in hand what they came to call the blue sheets. This was back when you ran things off on the copier. But we did a two-sided sheet on blue paper that had all of the questions we thought were likely to be asked with 3 bullet points that people could use as a response and a coherent key message that we used for many years, that safety is our top priority. So they were expert enough that when the journalists came barreling toward them with microphones out saying, "What is it that you're doing here today?" they could say, "You know, safety is our top priority. And today we're here to ensure the safety of patients." So I believe there's a huge role, and I think there's some discussion further about this today and tomorrow, for education to play in terms of inculcating communication as part of the educational process for the health professions. We find in my agency that we have some of the most highly trained scientists, not only in the nation, but in the world. And the last time that they had a communication course was never. And so learning on the job is one thing. However, having communication as part of the fabric of professional education and professional development, I think could help overall with many of the challenges that we face.
I'm totally in agreement with you. I'm totally in agreement with you. In fact, we're looking at what are the media competencies that health professionals ought to have. And we're saying media competencies, but I think it really is communication competencies with the public. How do you communicate with the public, even beyond the one-on-one? Nurses get lots of that. How do you communicate one-on-one? But they're not used to being out there communicating with the public at large. So excellent. And it's not just nursing, it's everybody.
Yeah. All right, thank you. Gary, I see there's some interesting questions in the Q&A line there. You want to offer one?
There are, and I've really been interested in these comments. And I have to throw in something myself first. When Jana was talking about miscommunication with the public over the pandemic, and we found this in organizations too that I've been involved with, the difference between being isolating and quarantining. And I'm just wondering, and you've answered that just a minute ago, to what extent is there a communications and education plan built into public health communications and crisis planning? And part of me thinks that the reason that people are being dysfunctional about this is because they really haven't been educated. And it just seems that we're really good about describing rolling averages, but we're not that very good at describing what that means to me in my house or in my everyday life. So I'm glad to hear that there are thoughts about that. Anyway, so we've got some good questions here. The first one is there a best practice for changing long-established institutional mindsets to an outside-in patient or a customer focus rather than an inside out institutional focus. I think Bob touched on that a little bit, but maybe one of the panelists would like to elaborate perhaps.
I defer to
You want
Bob.
us?
That's a healthcare question, Bob.
Yeah, okay, that's fair. I was just waiting. Sometimes I jump in too fast. So, thank you to the person who asked that question. That is something that we constantly need to remind ourselves is what is it that people need to know and how can they best receive it? Not only in terms of the channel which we can deliver it through, but also in the way that it's phrased and to make it meaningful to people. And I'll own sometimes not always keeping that in the forefront, but I sure do try because it's so vitally important. We do have conversations here with our strict communications, but also with our marketing in terms of sometimes we are tempted to make decisions and to deliberate in ways that, this is the way that makes sense to me as the mid-50s white advertising executive, male. And I have to remember, hold on a minute, the group to whom we're trying to reach out is markedly different than that. What do they want to hear? How do they need to hear it? And you can apply that, of course, to advertising and marketing, but you can also apply it to communications. Helping people understand how this pandemic affects them is paramount in the communications work that we do. And keeping in mind too that our 40,000 employees are not just members of our team, but more importantly, they're people in our communities as well. And so how can we share that information with them? Because they're scared just like all of us. They're a little bit over this whole thing, just like all of us. They're wanting to, get past these crazy times we're living in, just like all of us. So, so that's my long-winded way to say, I don't know, we're figuring it out, but it is important to frame things from the consumer or the patient's perspective.
Ellen, I think I remember a conversation with you a couple years ago about something you were doing at Northwestern to help prepare for patient-centered healthcare. Am I right on that?
Well, we started a professional master's program in health communication about 4 years ago now, and it's going very strong. I taught in it for 2 years and then passed it on to one of my doc students. And I was going to mention that program because because it's a professional master's, it was taught on weekends and a few times at night. And I was impressed by the number of people who were in that program. Many of them were nurses who had nursing degrees. There were a few doctors went through the program. And then there were a lot of other professionals who wanted to move into the healthcare area. That said, the second point that I would make was I did go out and do some, I won't say recruiting, but advertising about the program to different organizations. And one of the things that we were discovering is that a number of companies were bringing on site healthcare professionals who had health communication because they had health and wellness programs within their organization, so that the health communication professional was somebody who could come into a company, for instance, and work with people who are working with personnel on health and wellness issues. And a lot of companies at the time, this was at the height of the obesity crisis, a lot of industries at the time were interested in trying to improve the health of their own employees. Places like Wegmans, which is a very well-known chain of grocery stores in the Northeast. So I guess my point would be that health communication is becoming a much more popular area of study. There are other professional master's programs. There's one at the University of Illinois, as well as the one we have at Northwestern and several other places. That's point one. And point two, there's a great diversity of people who are entering these programs. These are usually one-year master's programs to become healthcare professionals. Some of them go back into hospital situations or health care delivery systems, but some of them are going into other industries to provide a mechanism to encourage the employees of those industries to take on health and wellness issues. Is that the question that you wanted to ask me about?
Thank you. And Dan, I saw you nodding and you unmuted. You want to jump on that? Now you've muted.
I thought I was. Sorry about that. Thank you for the comment and thank you for the possibility. And I do want to thank our panelists for sharing information with us. On this issue related to patient-centered care, as a hospital administrator and been in the industry for several years, we've been talking about patient-centered care for a long time. And I think there's a possibility for us to begin to develop programs within our institutions to really formulate ways in which we do that, not just during the time that the patients are getting care, but the pre-service time and the post-service time. So communication with patients, because if patients don't understand what we're telling them to do and family members can't connect with our communications, then I think that our care is going to be compromised for patients. I know here at Webster University, we've added effective communications not only into our introductory courses, but throughout the whole program is when we start doing case studies in which we're encouraging individuals in our student population to interact multidisciplinary way, because our student populations are made up of nurses and physicians and other health professionals. And it's interesting to see in my role as a hospital administrator, educator, how these individuals are beginning to work together. And it's also interesting to find out too that there's been some talk in the past that medical schools are going to start encouraging nurses and physicians to be trained together in the basic sciences and some of the programs that we have for medical degrees. So communication is vital, it's effective. And if we don't have it, there's no such thing as no communications. Either you have it or you don't.
Mm-hmm.
Comments?
Yeah. Thank you.
I have a comment on that. So
Sure.
first of all, 50 years ago when I was in nursing school, my undergraduate, we had courses like that with physicians and with others, just so, it's sort of rediscovering things. The other comment I would make about patient-centered care is that we give it lip service.
Right.
But
Absolutely.
as these health systems have become so large, my own experience and the experience of my husband, so both as patients and as family caregivers, is that it becomes assembly line care. The communication piece is key to it not feeling like assembly line care. And I'm not sure most health systems realize that. So I think this is right on target in terms of recognizing the importance of that communication piece, and not in a across the board way, but how do you communicate clearly and with what Jana said in a culturally relevant way with the patient that's before you. It's been very unsatisfying care when it feels like I'm on an assembly line and I'm not even trusting that they know that I'm on their line.
Yeah.
So I just like to say that I agree. You may be talking with me, Diane.
I know you're not like that. I know SSM isn't like that. I'm not talking about SSM.
Well, and in that vein, I would encourage you not to allow an anecdotal experience of two people to paint the entire industry of healthcare and big systems, because we do care about our patients. We work hard to make sure that we communicate with them, and we often fail at that, but we continue coming back and trying again.
May I say something sort of personal? In the last 2 years, my husband went through a very difficult time. He passed away, but he was in ICU after a lung transplant for almost 4.5 months. And the nurses were remarkable. They kept me going, as well as my husband, as long as he lasted. And they showed up at his memorial service. They've contacted me since then. We had become close. And so there are wonderful stories about nurses too. And it was a wonderful healthcare system. It was a great hospital. We were at Loyola Hospital in Chicago. So I have, and that was my longest experience with the healthcare system. I've been fairly healthy, knock on wood, but it was a great experience.
Very sorry for your loss.
So we have some other questions. Go ahead. I'm sorry, go ahead.
Sorry, I wanted to just speak briefly to the question of is there a best practice for changing an institution? I'm part of a federal institution. that has a near 75-year history and a culture. And communication, as one of the questions you asked, how do we make it part of, is it part of the thing? Yes, it is part of every emergency response. I can also tell you that in the meetings that we have, it's always last. So all of us in communication know how to talk like New York taxi drivers because we don't have that much time to get our point across. Within an organization, I actually have not studied whether there's an institutional best practice. I can tell you that trust is a huge issue, not only between us and the people that we serve, but within our own organizations. And I have found that trust in an emergency response happens between a medical or science professional and a communicator, first, if they know the individual. If the scientist does not know the communicator, they don't trust the communicator. And so one of the things that I have to do is build a bridge so that I can establish trust within the first 24 hours that I'm on the ground. And then I can start to build out from there. So a lot of it within the institution at my level as a practitioner is very personal, very individualized. And what we have done is we have gone straight to the smallest units within our center, the National Center for Environmental Health and Agency for Toxic Substances and Disease Registry, which I can say without taking a breath, and provided direct service to those particular units on problems and issues that they're having. And then we build a consultation practice, and then we start to change the way that people think. And I have had more than one scientist at my door looking at me and said, no one's ever told me about that before, or you evidently think about this completely differently from how I do. And then we can talk, and then we can start to change. Thank you.
Thanks, Janet.
You've
Gary,
all
you wanna
answered-
pick
you've all
another-
an- Go ahead.
Yeah, you want to pick another question from the audience?
Oh yeah, there are several questions here that speak to some of the things that you've discussed. But for instance, preparing institutions and professionals in how to communicate. For instance, we've got one question: what common communication shortfalls are there, and most frequent challenges communicating with patients, families, and care providers? And then the follow-up is, how common are training and development programs or similar strategies for healthcare professionals to help identify, correct, and preempt patient, family, and provider communications? And there's another question about the concerns about putting nurses in a situation where they're talking to the media without giving them any training or any communications or media relations kinds of training. So it speaks to the lack of or the possibilities for additional communications at all levels of the healthcare, education, and preparation areas. Is that, do you?
Yeah, I absolutely. I think it should be part of the curriculum. I want to speak though to the other issue and the issue of best practices around communicating and tie it in with the family visitation issue. So I blogged for JAMA, and I did a blog recently on rationing of care lessons about rationing of care during a time of COVID. And for that, I interviewed a physician at Mount Sinai Medical Center, as well as a nurse practitioner, and she headed up the palliative care team. And she talked about that one of the key issues was identifying who the family caregiver is, or who that contact person is for end-of-life discussions and for care preference discussions. And then they worked very deliberately to do that identification, to reach out to that person and engage them on a regular basis. They had a donation of iPad-like devices to be able to go into the room if the patient was able to communicate and have the conversation with the patient there and the family member there. Sometimes the staff person left the room so the individual could talk to their loved one. So I think there are some best practices around how to engage family members when you don't have the visitation policy, or you have a visitation policy that's very restrictive. And it's understandable why. You don't want your loved one getting COVID from a visitor. So, but I think it's the better hospitals that have that kind of attention to how are we communicating, not just with the patient, but with the patient's key loved ones, their family caregivers, their healthcare proxy, what have you. And there are some best practices out there that I think early on, a few hospitals developed, and it was at Mount Sinai Hospital in New York that it was developed.
You know, as the child of parents who are 83 and 77, I'll say that one of the disconnects sometimes in clinical communication is that they just don't really understand. And the caregivers, whether they're physicians or nurses, talk about this stuff every day. It's part of their normal environment, and they don't break it down quite enough for someone who doesn't live in it. And so that is one challenge, I think. And another equally important challenge is cultural sensitivities to communication and the ways that people need to hear information in different ways. We're all so different, and we need to hear things in a way that makes sense to us and that can be processed by the context that we've grown in and what our field of experience is. We're a work in progress, Diana, and I know perhaps I seem defensive about us in some health, but I will tell you that you know, we're constantly trying everything we can to help us be better for the people we serve, to help us respect and show compassion to the people we serve. We did the iPad thing that you're talking about, and as a matter of fact, I believe for bonus points, we had a nurse interviewed and a story about it. So I'm just really glad to be part of an organization that's trying to do the right thing. And your comments and everybody else's comments are right on. There's an awful lot of challenges with communication.
So another question we've got, and it speaks to application of new technology, I think. Are there basic communication models that can be followed by hospitals, academic centers during the pandemic like this that can ease that? One questioner asked about the utilization of Slack or some of the other communications platforms to help keep various constituencies within the organization equally informed on changes of policy and changes of procedure. What is the status of the use of technology in these areas?
Jana, do you want to speak to that? Would you like me to, or certainly Diane or Diana?
So yeah, thank you. One of the things that we do is we have vastly expanded our agency's social media presence. And to the extent that I did an inventory of Twitter accounts at CDC, and there were more than 1,000 because lots of people want to participate. However, there was only a fraction that were well followed. So I think it's very deliberate in terms of determining what is it that people are interested in, and then for Twitter specifically, aiming at that. Instagram can also allow us to micro-target, which, you know, if you're serving a population of more than 300 million people, micro-targeting is a little challenging. However, it's really essential these days because relevance is such an enormous issue in communication. So another thing that we do is we use our Facebook, Twitter, Instagram accounts in an integrated way, knowing that we have different audiences coming to those for different purposes. And then we can use those to build and bridge and lead people who want more information to our website. The other thing that we do that is enormously popular is we have 1-800-CDC-INFO, which is a 24-hour communication line where you can call in and ask about any health question. And we will provide an answer. And we do that because we prepare prepared responses so that whomever answers the phone can give a coherent response. And then we have a tiered system so that if the first response isn't sufficient, it goes to a second level and then to a third level to be able to move that forward. So to the best of our ability, we try to connect on a very personal level as a very federal environment.
Yeah, and if I may, Gary, to comment on the internal communications piece of that, I'd say that so to the question of, is there some, I think it said common or simple communications thing that can be applied to this? No. I mean, this is a global pandemic that's been raging for 7 months and is likely to go for a really long time still. So this is not common and certainly not easy, but there are some things that can be applied. So health systems, hospitals, everywhere go through emergency training, and that relies heavily on communications. And it's sort of a military hierarchy type setup. And at the local level, local regional level, you have a group that meets. There for a while, we were meeting every single day, 7 days a week. Now we're meeting still 5 days a week. But we're talking through, what are the things that have come up? What do we need to do? Where do you need help? You know, what are the issues? And sometimes communication is among those issues. How, you know, what do visitors to our hospitals need to know? What do our patients need to know? What does the public need to know? How can communications support that and get involved? And so in that way, I think we've been able to address this just about as well as we might have. We did, I'll say, like if you went back to early March, I rarely did video calls, and now I'm doing 4 a day or 5 a day, sometimes more. The introduction of technology, and for us at SSM, we were on Zoom for a while, and then there were some security questions about that. We've gone to MS Teams, and that's worked pretty well for us. Yammer is emerging within our organization, and we're sort of getting our hands around that as well. So I think that we're going to learn so much from our experience going through this pandemic together, all of us, not just my organization. I do hope I'm retired before we have another pandemic, but we'll see. It'll be Stephanie's show then.
Could I ask a question of Bob? So when your team decides, here's something and all of our staff need to know it, how do you communicate that with them? And do you have any numbers on what are the % of staff who actually read the message?
Yeah, so man, you have asked the tough question, because we struggle with that, just like a lot of organizations. So some of the existing tools pre-pandemic that we're still using are things like we call it My News. It's a weekly email newsletter that goes out. And depending on the campus, maybe 40% of people read that, something like that. We also, when the pandemic began, we began to have those daily meetings of leadership and to talk about all these things. There was so much that our staff needed to know that we began putting out a daily email that would go out to staff that would summarize what we call taskers. They are, you know, here are the things that you're expected to know and to do. And then Stephanie, who you see on your screen here, was also taking those taskers and building leader talking points every single night, late at night, to put in the leaders' hands so that they could share those during department meetings and make sure that people heard firsthand. And then old low-tech Bob here put together a phone line so that people who were off campus and weren't on to be able to look at their emails or whatever, they could call into this toll-free number every day and hear an update that was essentially a reading of the daily email that went out. So there's nothing quite as encouraging as getting right to the end of a 4-minute long, 5-minute long message about everything we're doing and having your dog lose her mind at the Amazon delivery man and having to re-record everything. But it's been a great experience to be able to learn and to grasp onto some new things. And I would absolutely love to hear, like, if there are other people, even in the participants, who've found some other way to communicate with a geographically dispersed huge amount of people. We are wide open to new ideas.
I will mention that the idea of a Slack channel is intriguing. We used it in my local community, I'm now in a rural community in upstate New York. We, a number of people are on a Slack channel for COVID related things. And the use has waned a bit, but we found it really helpful to have one place where we could go to and get those updates. And it'd be interesting to see if it would be of value in healthcare organizations.
Thanks for that. That's great.
We've had another question about you had alluded to this, the concern of healthcare institutions about continuing care during the pandemic, elective surgeries and continued follow-up of chronic conditions. One person asked, is there any way that you can assure or reassure the public that they are going to continue to be able to get their continued therapy, such as chemotherapy or physical therapy, that are needed in order for them to continue their health without putting themselves at risk during the pandemic?
Yeah, so if the other panelists don't mind, I can jump on this one first. I feel like that's a communications message that we already are attempting to disseminate daily right now to help people understand that it's important that you continue getting that care, like the types that your question asker asked. The things that we're doing, like much more frequent decontamination of surfaces, distancing within the hospitals. Everyone must wear a mask in the hospital. It's not optional here. All of these things are done in order to make the care environment as safe as it possibly can be. And that includes, in some cases, visitor restrictions, although those are a little bit more relaxed at the moment. I expect they may be going to a bit more restrictive based on the elevation. People need care. People needed care before COVID. People continue to need those types of care even during COVID. So to the degree that we can, we remain open to provide that care. And then some types of care like chemotherapy you talked about, I mean, we're going to offer that care no matter what. We're just gonna have to do every single thing possible to keep that person as safe as they can be.
So Bob touched on one of the most important principles of risk communication for an organization, which is we need to talk about what we are doing, specifically what we are doing. And in the case of a healthcare institution, potentially specifically what we are doing to keep our cancer unit safe so that you can come in and receive treatment, or to keep our general admission area clean and safe. And then the second thing is, if we're requiring people to wear masks or take some other measure that they haven't typically taken, explain why, so that they have that context. And but number one out of the gate for risk communication, especially if the event is evolving and we don't know what's going to be happening, is we talk about what we are doing. Here's what we're doing. We don't yet know this, but we are taking these steps to answer that question. And then you follow up the next day, or with a good periodicity, to say, you remember we said we were looking at this. Here is what we found. Now we're taking this step. And you just keep repeating it. We think we know those things. We are confident in those things. But if we don't describe in detail exactly how are we sanitizing those areas, what areas are being sanitized, how frequently are we doing that, how many people are involved or engaged in that activity, that gives people a much greater sense of assurance.
Context is good medicine. We got another question here about what would be some of the best practices for cross-training between various medical professions?
Well, now you're asking me a question I'm probably not qualified to comment on. I know Diana is a lot more connected to nursing profession, at least. Any thoughts on that?
Well, I'd say over the last decade at least, there has been a real strong effort in interprofessional education. And so I think it is going on. There are some barriers, such as the medical the medical schools often have a curriculum, an academic schedule that doesn't match any other school's academic schedule, which makes it difficult to have joint classes, but they're working on those things. So I think there's a lot of work out there that's underway. The Josiah Macy Foundation has supported a lot of that work, as have other foundations. And the University of Minnesota, Barbara Brandt, I want to say, has headed up a Center on Interprofessional Education for a number of years. So I think it's quite possible. It's while they're in school. When you're talking about professional education on the job, I think it's really hard to get everybody in the same room at the same time. That was my experience when I was Director of Education and Research at a hospital.
I was just going to make a comment to Bob. One of the things that I've seen is that service line development, identifying the service line and all the component pieces for that clinical care, usually is multidisciplinary in approach. And I think there's a good opportunity to start training individuals on the importance of the message, the pre-service message during the operations or during the clinical care, and then the post-service message. So I think service line delivery is a way of taking the silos that we have in healthcare, where we have nurses and pharmacists and physicians and other people, and crossing through them and making sure that people have a understanding of what the other component pieces do. You know, healthcare is not delivered by one person.
Right.
It's delivered by a multitude of individuals, and bringing those individuals together that are participating in that particular service line, I think is a way of training them, not only in communications, but a better process for quality and outcomes.
Yeah, very well said.
I'll say it again then, Bob.
We have one remaining question, which I think we've touched on, but they speak to trauma-informed care communications, and is trauma-informed communications being taught as a part of the curriculum for physicians, nurses, physical therapists, and other healthcare professionals? I think we touched on that, but perhaps there's something that would be a follow-up.
So my understanding of it, and I'm not in academia right now, is that academics are behind on that. I think there are some efforts that are being made. I know of in Philadelphia, the 11th Street Family Health Service, which is a nurse-led community health center, has been certified as a trauma, I forget the language of it, but they have all been trained in trauma sensitive care. And so I think it is the next step for many organizations to start looking at what that means and how do you teach it, and certainly in schools, but also how do you teach it in interprofessional. I like that service line approach too. I think that's a really good approach. I don't think we're there yet, but I think it's starting to emerge.
That concludes our questions. And now I think Dean Rothenbuehler would like to summarize.
Yeah, oh, summarize, huh? Okay. Well, I was thinking we had come to a nice spot to sort of wrap up our first panel, and that'll give us a few minutes for a break. Before we go, though, do any of the panelists have a last thought or something they want to share, a point of emphasis or anything? So thank you, everyone in the audience. Thank you, everyone on the panel, and we will see you again in a few minutes.